I'm going to give a talk on a career in medical physics, and that partially will include a little bit of physics. There is a partial physics learning component to this lecture, which I hope will excuse me, help to inform what it is that we do and the role of a physicist in the whole radiation oncology process. So the title of my talk is Physics and Radiation Oncology, Imaging and Therapy. So first off, what's a medical physicist? Well, we're healthcare professionals, and we specialize in the application of physics in a variety of fields, actually. My specialty is in radiation oncology, and that's where most medical physicists practice. We work in clinics. We work with patients in the treatment planning and delivery of radiation typically for malignant tumors, for cancer. There are a portion of medical physicists who work in diagnostic imaging, so typically involved in the QA, the quality assurance, that is, of things like CT scanners, X-rays, making sure that they're working and delivering radiation as they're supposed to. And there's also a number of medical physicists working in radiation protection, so typically one in each center that will work with radiation to make sure that it's delivered safely and radioactive isotopes and sources are handled safely and transported safely. So this is roughly the distribution. As I said, most of us are in radiation oncology. In general, we do have a variety of different responsibilities, like clinical service, like I said, radiation safety. A lot of us work in research and development, and that's, as we'll sort of get into later, that's one of the really attractive parts of being a medical physicist. It's getting to work in a clinic, and at the same time, perhaps being cross-appointed to university and doing research, having students, and trying to develop better ways of treating cancer. It's pretty exciting. And as I'm doing now, there's a component of it that's teaching. So I'm going to start off with the electromagnetic spectrum for those of you who aren't familiar with this. Most of the energies that are of interest to us are in the ionizing range. So this is in the high frequency, high energy range. So over in the low frequency range, we have things like radio. And as we move over to the left, we get into higher and higher energy photons. So right here, everything with more energy than ultraviolet rays, X-rays, and they call them gamma rays here, and maybe we'll talk about what the difference is, increasing all the way up to cosmic particles that come flooding through from the sun. So I'm going to talk a bit. The physics component of this lecture is really trying to teach you guys something about what ionizing radiation is and how that differs from non-ionizing radiation, which, as you remember, is everything sort of to the right of this. So at sufficiently high energies, photon energies, and this is the energy of each individual photon, when they interact with matter, they tend to strip electrons from the atoms that they interact with. So this is to distinguish this from non-ionizing radiation. Electromagnetic radiation that's at about less than 10 electron volts in energy doesn't ionize, so it doesn't create free electrons as it passes through matter. So typically what we get is photon scattering. Does that make sense? So that those electrons are still bound to the atom. Right? So an important part about this is the photons, since they haven't transferred energy to the atom, they retain their incident energy. In contrast to this, there's ionizing radiation. So this is greater than 10 electron volts. And note this, the intensity, the number of photons, doesn't matter at all. What matters is the energy of each individual photon. That's important. So in ionizing radiation, the interactions strip those electrons off, and those electrons then travel on through the tissue. So there's a transfer of energy from the photons to the tissue. So how is this useful for things like diagnostic imaging and therapy? Why are we interested in this? Well, let's look at imaging first. So think about optical imaging, seeing, taking photographs. If we have something like a piece of bone in a dish of clear water, and we're at sort of a visible energy, so a fairly low energy, what we get is we get transmission of the photons through the clear water and reflecting off bone. So if we were to look into a dish that had a piece of bone, we would see the bottom of the dish, and we would see the bone. However, if you were to have instead perhaps an opaque gel in that container, almost by definition, you can tell what's going to happen. We call it opaque for a reason. At optical wavelengths, we can't see any of that. And the same analogy holds in tissue. It's why I can't see your bones. So one of the useful things about ionizing radiation is that higher energy photons are less likely to interact with matter. So what happens is we get greater penetration of these photons into different media. So now let's look at, say, 20 keV. So this is, keV is 1,000 electron volts. So 20 keV, now we're at ionizing energy levels. So we're getting some penetration into the water. And the actual distribution of this depends on a particular probability. So you're going to get some photons that are going to travel straight through. It's just that they're a very low probability that they're going to do that. The average photon penetrates into water by about 1.3 centimeters. So
would this be the typical kind of X-ray?
This is actually a bit low, right? So this is on the very low end. And I used 20 keV for a reason. So remember, keep that in mind, 1.3 centimeters. So now let's turn this up to 100 keV. And this is closer to what diagnostic imaging is done at. So your typical X-ray CT scanner will be in this range. Fluoroscopy unit will be about 100, or in the order of 100 keV. Right, so now the mean depth of interaction is about 5.9 centimeters. It's not to say some photons will go further, some photons will attenuate sooner, but that's the mean depth. One more thing I would want to try to convey to you guys about photon absorption is that it depends on the energy. It depends on the interactions with matter, and the types of matter depend on the energy. So at low energy, what we would call the keV range, so in the thousands of electron volts, the atomic number of the material strongly influences the absorption. So different materials attenuate very differently. At higher energy, the absorption tends to be roughly independent of the atomic number, so independent of the type of the material, roughly speaking. So at, say, about 50 keV, so this is a low energy photon, the range of 10 to about 100 keV, the photons tend to be completely absorbed when they interact. It's part of the photoelectric effect, if you guys are familiar with that. So what's going to happen is these photons, in something like lead, which has a very high atomic number, there's a very high probability of interaction and a very high probability of ionization. This is why if you were going to get a dental X-ray, they'll tend to put a lead vest on you. And it doesn't take much lead, really, to stop any of those diagnostic X-rays from passing through your body. So, and if you're interested in a bit more, the probability of interaction scales at about z cubed. So it's a very strong dependence on the atomic number. Now contrast that to something like water, which has a much lower. And this is an effective atomic number, but let's not worry about that. The Z is much lower. What's going to happen is we're going to get some interactions, but a large number of these photons won't interact. So they're less likely to interact with a lower atomic number of material. Now let's look at higher energies. At higher energies, the probability of interaction is almost independent of the atomic number. Not quite, but almost. So it doesn't really matter what type of atom we're interacting with. What ends up mattering, actually, I'll skip ahead. What ends up mattering is the electron density, the number of electrons there are to interact with in a given volume. Right? So because we're scattering off the electrons themselves, that's what matters, how many we have to interact with. And another important thing about high-energy photons that we'll get into when we talk about therapy is that these photons, as they scatter from the atom and ionize these electrons, they scatter forward. So these photons are typically capable of ionizing again and again and again in a cascade. So let's look at this. We're in this opaque gel, and we have bone, which has an effective atomic number of about 12.3. And this gel we're going to say is about water, which has an effective atomic number of about 7.5. So in the keV range, the low energy range, what do we get? We get reasonable transmission through the low Z, and we get differential absorption in the higher Z material. So if you have a piece of film under that, we're going to get exposed regions on the left and the right of the piece of bone, and less behind it. Now, let's turn this up to MeV. Same setup. What we're going to get is greater. There's still going to be some attenuation in the bone, but we're going to get many more photons through. So we're exposing the film, this piece of film underneath the bone, far more than if we were to be using low energy keV photons. So, first question. Here are two X-rays of the same patient. These are chest X-rays. Which one do you think was taken with a high energy beam? the high energy beam. So
On the right.
on the left, you're going to guess right? And guess why?
There's less contrast on the right.
Yeah, so what we have here is the bones shielding the film. You can see that. Also here in the mediastinum, right? There's more material here, and so it's great. The attenuation is much greater. Here, there's far less bone contrast, far clearer delineation of the lung and the diaphragm as well. Does that make sense? Yeah? Cool. So here's a really high Z material. Now probably what you're thinking is this is less about photon interactions and more about my skills with Photoshop. But this is an actual patient. He presented about 5 years ago in London. This gentleman was 85 years old, and he had a very bad case of hemorrhoids, which he would self-treat by using this artillery shell to hold the hemorrhoids inside him. One day it went too deep, and he went to a hospital in East London, and the doctor saw him and took this X-ray. And he said, "What is that?" And the man said, "Well, that's an artillery shell from the war." And the doctor said, "Well, all right, well, we're going to get that out of you." So the doctor started taking it out, and the man said, "Well, just be careful with that. There's enough ammo in that to take out a Messerschmitt." And the doctor said, "You mean that's live?" And the man said, "Yeah." And the doctor took, I can only imagine, 3 steps back. He actually did call the bomb squad. They erected a lead wall around this man, and they diffused that inside tube. So there you go. You see all kinds of things. Anyway, as far as physics goes, look at the contrast of that, right? That brass shell. So now we're going to kind of move on to radiation therapy, and let's start with a little history. So Wilhelm Röntgen, the pioneers of radiation therapy, discovered X-rays. So I want you to pay attention to the dates and sort of how close the times were between when X-rays were discovered and when they were actually being used. I mean, it's pretty incredible. So he produced the first Röntgengram, which I'm going to show you, the first X-ray, really, of his wife's hand. And within months, this is an incredible rate of translation from sort of first discoveries in the clinic to actual applications. And on January the 12th, 1896, this is like maybe a year later, radiation was being used to treat tumors. It's pretty impressive. I don't think they were, as you're maybe going to see, maybe they weren't that successful. And of course, everyone knows Marie Curie, and it's really nice to feature a woman pioneer like right up there. Won the Nobel Prize for this discovery of radium in 1898. And the effects of radioactive emissions on tissue, particularly, of course, like skin effects, very obvious, were noted early on. In 1903, the clinical use of radium began to treat cancer and other diseases. So this is encapsulated radium. Typically, they would put radium inside the capsule and then insert it close to the source, a type of treatment called brachytherapy, which is my specialty, and I'll kind of show you a slide on later on.
If the biological effects of radiation were understood already, why was there such carelessness, do you think, in handling materials?
It's a good question. As a physicist, I'm going to say, first off, I don't know. But my guess is that because typically you think the kind of things that would present early would be things that look like sunburn, right, in an overexposure. But the late effects of radiation, the type, like things like necrosis, second malignancies, cancer, and stochastic effects, the things that don't necessarily happen to everyone and depend more on
So I guess they were concerned about the acute effects, but the chronic ones they weren't.
Yeah, definitely. And she didn't actually die of cancer. She died of anaplastic anemia. So her bone marrow basically just stopped producing red blood cells. Right? They were overexposed. Bone marrow is very susceptible to radiation. In 1920. She founded the Curie Foundation. It's a Center for Radiotherapy. So again, this is 25 years afterwards. It's pretty impressive. And this is the Röntgengram, the image of the hand with the ring. Here on the left is they used to use radiation to fit shoes. So you'd put your foot in the shoe, and you take an X-ray of it to see how it fit. I have a picture which I didn't put in this slide presentation, which is actually the machine that you would kind of insert your foot into, and it would take the X-ray. And on the right, a radiograph of a human brain, which is actually really amazing quality, given the types of tubes they were using to generate X-rays. So one of the first documented, published cases of radiotherapy was in July of 1896. And this was an irradiation for stomach cancer, so a gastric tumor that was fairly deep-seated. And the physician observed, quote-unquote, observed improvement in the tumor. However, when they went back and looked at the treatment setup, they found out that the X-ray energy was a maximum of about 20 keV. Now, if you remember, the depth of penetration, mean depth of penetration of a 20 keV photon is about 1.3 centimeters. So do you think this treatment could have been therapeutic? Very unlikely. 20 keV photons simply don't penetrate enough into tissue to deliver what's typically what's a therapeutic dose. What would have happened is he would have had terrible skin effects before any effect on the tumor itself would have been seen.
Sounds like a placebo effect.
Yeah, or a research publication effect. So really, effective radiotherapy needs MEV photons. And we had to wait until the nuclear age to get that. And Canada really was a leader in this. Cobalt-60 is a radioisotope produced in Chalk River. The sources have to sit in there for about 2 years for sufficient activation to produce the type of radioactive source that's useful for therapy, something with enough activity to treat a patient in a reasonable amount of time. And the energy of cobalt-60, decay energy, is a mean of about 1.25 MeV. So this was really the first clinically viable megavoltage therapy. And you can see some of the pioneers in the Saskatchewan hospital using it on a Phantom. And there's the commemorative stamp, which is really neat, from 1988 of that Theratron unit. We have its predecessor. We still have cobalt units. They're still very useful for things like calibration because the source decay is just so stable in comparison to other means of generating radiation. So we actually have one in the cancer agency.
Is it just X-rays that are used now? High-energy X-rays?
That's a great question. So that's a perfect time for me to explain the difference between a gamma ray and an X-ray. So quite a common misconception is that a gamma ray is a high-energy X-ray, whereas really, technically, a gamma ray is an X-ray that's been produced by radioactive decay. It's the means in which that high-energy photon was generated rather than its energy. So you could have low-energy gamma rays, high-energy gamma rays, and low-energy X-rays and high-energy X-rays. There you go. So these days, we use linear accelerators. So these have no radioactive source inside them. They generate a photon beam which comes out of that aperture there by accelerating electrons and smashing them against a target. And this process produces a stream of photons, which is used for therapy. So it's nice that you don't have to worry about taking care of a radioactive source. It's nice because you can have energies all the way up to 18 MeV. Right? So you can treat at a bunch of different energies suitable to the type of depth of tumor that you're trying to reach.
Yeah, sorry, go ahead.
So this thing has a switch as opposed to a source.
That's right. Yeah. It has a waveguide in there, and depending on the acceleration potential that you put across that, it accelerates those electrons to different speeds, to different energies, right? And so your peak photons are coming out at exactly the maximum accelerating potential on that electron.
It's good for the sport. I remember a story in Mexico dump site. Some kids found an old cobalt-60 that still had cobalt-60.
Yeah, it was still glowing, and that's one of they're still heavily used in the third world. One of the things about these machines is they require very stable power, right? They're very expensive. The units these days are on the order of millions of dollars, $2 to $3 million, and they require a lot of maintenance. Whereas cobalt, you need a source, you need something to shield it, you need something to open and close the aperture. It's very simple. One of my old supervisors was very keen on a story where I don't know how many of you remember the power outage on the East Coast back in 2003, where the whole East Coast shut down, and they were doing palliative treatments on cobalt because there wasn't enough juice to run these. So I should point out that what we have here, and this is the first time you'll have seen a treatment unit, is the patient lies on the bed here, and this is the treatment beam, and this gantry actually rotates, as you can see there, and there are lasers that they use to position the patient for treatment. what you see on the left and right, this is basically an X-ray system. So that's used to actually ensure that the patient is lined up in the same way that they were planned. Right? So they take what they do is, I'll explain this in a bit, they take a series of CT scans, they decide what the radiation distribution is going to be, and then they put the patient in the same position and deliver the treatment. But let's take a small detour, because I haven't really talked about why we use ionizing radiation for cancer therapy in the first place. Why is it therapeutic? Well, in imaging, we've just been really paying attention to the unscattered photons. But really, there are all these electrons that I haven't talked about yet. And these things are propagating, creating secondary ionizations, and depositing energy all throughout the tissue. So what you're seeing here is an example of all the interactions that stem from a small group of interactions in the center. Right, so there's a cascade effect. As one photon has a primary interaction with an electron, that electron may go off and create a cascade of secondary ionizations, and those propagate outward. So actually, the calculation of how energy is deposited in tissue, which is called the dose calculation, is all done by computers. And it's actually not a trivial calculation. It requires some pretty sophisticated techniques. So what's the target? Really, why is this therapeutic? So these ionized electrons, what do? Well, they hit DNA. And DNA really is the target for radiation therapy. What we get is a track, an ionization track, producing excited electrons in these ionizations. And it will actually break. It'll do damage to DNA strands. What happens is these energetic electrons, after they cause the breaks in the strands, the cells tries to repair this damage, but often it's unsuccessful. And what you get is aberrations in the chromosomes. Right? You get these kind of deformed chromosomes that you see on the right here. And when these are, some forms of them are stable, which is to say that they were repaired incorrectly, but the form isn't going to cause cell death. And there's unstable ones, and these do cause cell death. And what happens is this results in reduced tumor volumes and hopefully a cure. Right? So the cells that are affected by radiation end up dying because of DNA damage. Right? We don't heat them up to distinguish that. Right? We're not cooking these cells. We're damaging the DNA, and the cells die naturally, right, from reproductive cell death. Right, from the body's natural mechanisms for taking care of and destroying damaged cells. Because cell damage is happening all the time from the cosmic rays that pass, from the things that we eat, from cosmic rays passing through the Earth, from background radiation that's coming out of the ground as we speak. Right, so our body has sophisticated mechanisms to deal with it, but when it can't, cells die. So it's also really important to understand that radiation affects cancer, normal tissue, and to first approximation about equally. Right? So there's nothing in particular, obviously special about the cancer cells that we're targeting. In some cases, like the small bowel, it tends to be even more sensitive than the target volume, which you're trying to treat. So the goal of radiation therapy is to try to get a really high dose to the tumor while sparing everything around, right, that could cause complications and side effects for the patients.
Well,
So,
one question about that.
Yeah.
What about things like adjuvant therapy when you're just trying to reduce the risk of recurrence, like breast cancer? In that case, it might not be a tumor left, but it could be. You're irradiating to reduce recurrence.
I think you mean palliative treatments. Do you mean to reduce the pain?
Reduce. It's also used to reduce the risk of recurrence.
That's right. So we aim for a cure.
Yeah.
That's right. So sometimes we're unsuccessful. But there's basically two streams. There's radical, definitive, curative therapy, where the goal is to try to eradicate that tumor. And you don't get a second chance in radiation therapy because the chronic effects of radiation in that tissue mean that if you try to hit it again, you may get some really nasty side effects. So it's really important that you hit that the first time and you get it right. Typically, if you fail radiation the first time, your options are rarely more radiation.
But like in the case of breast cancer, they can remove, after tumor removal, they can remove the breast, or they do radiation treatment.
Yeah, that's right. So sometimes clinical trials have shown that the best way of treating patients, more patients survive with less complications by doing things like that, combined modality therapies, where they will excise the tumor and then do a post-irradiation, or vice versa. Or even combine various forms of radiation therapy or radiation with chemo. Right? So all these things work together. The radiation oncologist will work with the medical oncologist, will work with the surgeon, right, to try to come up with the best mix of treatment flavors to guarantee that, hard to guarantee a cure, but maximizes the probability of having
The
it.
cancer cells are still affected more than the regular cells because of the higher rate of reproduction of DNA, right?
Yes, yeah, you're correct. Sometimes it depends. There are some, like I said, the small bowel tends to be much more sensitive than really anything else. But yeah, I'm not going. There are definitely higher order effects, but it's important to know that it's just not. What I'm trying to convey is it's not just tumors that are being affected by this. Right? We really have to pay attention to normal tissue, and it's almost always the normal tissue that affects how much dose we give. If we weren't afraid of normal tissue side effects, we would just give more dose, because the more dose you're getting, the higher the probability that you're going to kill a cell, and ultimately the higher the probability that you're going to cure the tumor. Does that make sense? We're almost always limited by toxicity.
Does anyone have an idea of how often radiation therapy actually triggers a new cancer by DNA damage that doesn't kill the cell?
It's typically not. If it's in the target volume, it's expected that it's going. You're attempting to give it a really high dose. Second malignancies are a problem, so often you don't. Radiation, you tend to try to avoid it in younger patients, like especially children, and especially who are still growing. But the rate of second malignancies typically is quite low, and we look at it from the perspective of the potential survival of the patient if they're not treated versus the very small risk that they'll develop second. But it is absolutely a concern, and it's one of the things when we do treatment planning, we try to minimize how much of the treatment volume is being irradiated, even if we're not anticipating a particular acute toxicity event. Okay, applying information. So this is what happens when a patient visits the clinic. I want to kind of give you a quick overview. So the patients show up and they get the diagnostic images, and this all goes into like an electronic database system. Then what happens is if the physician decides that they're going to receive radiation, they go in for CT. We actually don't do that anymore. They go in for CT imaging and a virtual simulation. So we take the CT images, and it's important to understand that these CT images are taken in exactly the same, as much as possible, the exact same patient setup geometry that we're going to treat them in. Right? That's why it's called simulation. We try to get them into the position we're going to treat them in, and then take CTs. So we have images of them in exactly the position we're going to treat them in. And then we put them into computers that model their bodies, and we put virtual beams of radiation, and we let the computer calculate what the expected distribution of radiation dose is going to be in the patient. So this is the process of planning. Right? So we have the dose calculation, where we calculate what's happening with all those photons and electrons inside the tissue, how that energy is being deposited. And we typically aim to deliver a certain amount of radiation depending on the treatment site. And we try to optimize that. So as you said, we try to minimize how much radiation we're giving to your whole body and to the organs around the target. Then what happens is after we've planned the treatment, we send it to the computers that are going to control the actual treatment, control the machine that delivers the treatment, and if there's any special accessories that we need to block the beam or to shape the beam, those are produced. And then, as I showed you, some of our units have X-ray images on board, and we do any on-treatment day image guidance that may be necessary. So if we expect the patient to be in a certain position, we may take a few X-rays and then ensure that those X-rays line up with the way we expect those X-rays to look, given our CT data set that we took in the simulation. It's a really, really quick run through that. Does that make sense? I see some nodding. Okay, so the process of actual treatment planning. So that's basically what takes place right here. So first what we do is we take that CT set, and then we localize and we define the tumor and target volume. So this is not something medical physicist does. This is something the radiation oncologists do. They look at the CT, they draw lines around the treatment area, the areas that they want to treat on the CT scans. Right? They contour the patient. So that's the outer surface of the patient. They mark the target volume and any relevant structures that they're concerned about, things that may be affected adversely by the radiation beam. So now we get into the physicist. The physicist determines the best way of delivering the radiation. See, probably the simplest way of understanding.
It's like trying to aim it to avoid an organ and the bone?
Yeah, exactly. So we have this kind of, it's a virtual patient, and then we can manipulate the beams, and so we get beam's eye views, right? So it's like we're looking through the beam, and we try to maneuver it so that we're pointing it at the target and avoiding everything else. It's a simple way of describing it. Does that make sense? So it's almost like a 3D modeling system where we have this model of the patient and model of all these beams, and we're moving them around trying to find the best way of delivering a radiation dose to that tumor volume. Yeah. So the beam configuration essentially describes like the geometry of the setup, like how we're going to place it, or rather how we're going to maneuver the patient and that gantry of that linear accelerator to deliver that particular beam. So it's iterative, right? This is a process of I'll call it trial and error, but typically with experience, you have particular plan templates. You set it up in a particular way, intend to treat the same type of tumor sites the same way over and over again. Right, so you set up the basic initial beam that has worked for many other patients. Right, you calculate what that dose distribution is, and that will vary by patient to patient in as much as human bodies differ. People are different weights. Some people have larger or smaller organs. So if we have to improve this dose distribution so it doesn't meet our requirements for what we expect we would need to achieve a cure, we modify the beam configuration. And then we calculate the dose again, and then we make modifications, and we try to iterate towards an optimal dose distribution. And then, actually, I probably should have removed this, but it's interesting. One of the really important parts of being a medical physicist and delivering this, remember in that previous slide, one of the important parts is that we then, after we create this plan, we pass this on to someone else, to the radiation therapist who's going to deliver this. So it's really important to be clear about precisely what we want done. So let's talk about the planning. I'm going to show you some images of the planning system. So we have these multiple X-ray beams that we're going to use some different angles to try to intersect the treatment target and deliver the most dose at that point. And so these beams are shaped using physical cutouts or a device called an MLC, a multi-leaf collimator, which I'll show you in a second. So here's an example of a cylinder with different beams being projected onto it. This is what it would look like in the treatment planning system. And here's an image of the orientation of the patient for reference. So in this case, we would be trying to hit perhaps this target, and we would be trying to avoid as much as possible treating these structures.
So is the idea that the damage is highly non-linear with dosage?
Cure tends to be, because remember, it only really takes a very small number of cells to repopulate a tumor. So there's very little point delivering anything less than a therapeutic dose. Right? There are threshold doses at which effects start to happen. Yes.
Is there ability to be selective like that? Is it a recent development? How long have we been able to deliver beams precisely where we want them?
So I'm going to show you a slide in a bit that shows sort of the progression of treatment planning techniques. The ability to precisely deliver, there's different components to this. There's the accuracy of our ability to position the patient, which is improved. There's the accuracy of the actual machine's ability to produce radiation in a reproducible and in a way that we can accurately characterize. That's improved. And there's also our ability to calculate what those beams are doing, right? To calculate those complicated dose distributions in the patient. And that's also improved. So these things kind of move together. So it started off really simply. It started off with, back probably, I don't know the precise date at which we moved to complicated 3D planning systems, probably in the 90s, I would say. Before that, it was all done on X-rays. So you take an X-ray, you'd outline your target, and then you'd have your beam's eye view. You'd know what that X-ray looked like, how that target was going to look. So if I was trying to treat something with your contour, I'd have a beam like that, and I would block off. Maybe if I was trying to treat your torso, I'd block off your head, and the doc would draw a line across that part of the X-ray. And then what that would do is the person who manufactured the beam cutout blocks would take a look at that, and he would create a piece of lead, and he would cut it to shape, and he would just place that in front of the beam, so your head wasn't being treated.
Pretty rudimentary.
Yeah, it was very rudimentary until really computers and the ability to do this 3D modeling has moved us forward, and I'll show you just how much. So here's an example of what a physical cutout looks like. So this is actually an electron treatment. So let's not worry about the types of particles that are being used here. But here's a lead block. So what the doctor presumably wanted to treat was a region in there. So this was made out of a lead-like material called ceraband. So that was shaped in accordance to the treatment plan. And what you're seeing here are lines of iso energy distribution. So each one of these lines represents a region, and within that region, the dose is higher than what's outside that region. Right? So you can see the energy, and these blue, as the colors trend from orange into green and blue, you're saying what that's telling you is that there are lower and lower energies being deposited further and further from the skin surface. Does that make sense? So this is one of the ways in which we represent energy deposition in these virtual patients, using these lines which represent how much dose is being delivered. This is a multi-leaf collimator. So we talk about how we used to. So one of the ways in which you could shape something is actually shape a beam is to cut out a piece of lead. Another way is to use a device like this, which has these leaves which can articulate back and forth and create virtually any shape up to the resolution of the leaves themselves. So this can be programmed from a computer to assume a variety of different shapes. Typically what you do is you conform it, right? In the more sophisticated technique that came in the 90s, right? You conform your treatment beam to the tumor using this MLC. Is that clear? Right, so you'd fire the beam through that, and if the shape of your target was, say, in red, that would be the outer shape of your target from that particular angle in which your beam was entering the patient.
Perhaps you already mentioned this. Is there a range, a distribution of energies that you're irradiating with? Or?
Typically, we irradiate with either a 6 MeV beam, a 10 MeV beam, so a low and a high we typically play with.
Okay.
So if there's greater separation, if the tumor sits deeper, often we'll switch to a 10 MeV
So the
beam.
10, what's the range of that 10 MeV?
That's the spectrum. That's a really good question. I've avoided talking about the fact that these beams are not monoenergetic. We don't deliver, not every one of these photons has exactly the same energy. In cobalt, the cobalt-60 source, it's highly monoenergetic, right? Well, very close to monoenergetic.
Yes, right.
But these things, because what we're doing is accelerating these electrons, not every electron is going to decelerate.
I was just thinking about that because I was thinking the radiation that penetrates furthest is the highest energy.
Yeah, so if you have a spectrum like that, yeah, you're going to see a smear in how the energy dissipates. Yeah, that's very astute of you. It's true. So we get a spectrum where the peak energy is our maximum, and then it decays from there. And actually what we tend to get is a process called beam hardening. So as these photons pass through the patient, their spectrum moves more and more towards the higher energies because the lower energy ones are getting selectively attenuated.
Wouldn't you want a spectrum so you get deposition throughout the tumor of same energy, so you get,
Some fuzziness.
Yeah.
Yeah, ideally, we're kind of limited by physics. It'd be nice to design photons to do what we want, but unfortunately. Now, proton treatments you should look up when you go. Now, high-energy protons behave very differently, but that's sort of beyond the scope of this. But look it up. They attenuate they behave very nicely in a way that's very conducive to treatment.
Hey Nick, is the synchrotron source in Saskatoon, is it more monoenergetic than your Linacs?
Yes.
Yeah.
Definitely.
But you can't bring it to Vancouver.
No. I mean, to treat, if you guys get a chance to go see Triumph, the proton, the cyclotron out in UBC, right? These things are enormous. The installation costs to produce protons is really high. And that's one of the limiting factors. Okay, planning. So this is an example. So you're asking about different techniques. So kind of the most basic technique that's been used since the days before we had complicated 3D planning shows the dose distribution on the left. So here, in each of these different, this is the same treatment. This is the target outlined in red. These are structures that are trying to be avoided in kidney, spinal cord. And what you're seeing here on the left is, what these lines represent are those energy distributions, right? So the lines of what we call isodose. So everything inside this yellow box is receiving more than 25% of the treatment prescription dose. Everything inside the green is receiving more than 95% of the prescription dose. So you can see that this 95% volume, which is our therapeutic treatment level, we're trying to cover this treatment volume in this 95% region. There's an enormous area inside that 95% region. So how we used to generate this was a system called parallel opposed pairs of beams. So we basically beam in a patient on either side to generate that distribution. A more complicated beam geometry that produces a better dose distribution is a 3-field treatment. So we will add a lateral field to this. and we'll also typically wedge. So we'll put in these little doorstop-shaped pieces of metal. Can anyone guess why we would do that? So we put these in front of the beam so that the photons that are passing through this side of the wedge have to pass through a very high, much higher Z material than on this
To
side.
get a more monochromatic beam?
No, it's not to affect the
It's not the
beam.
hardening?
It's not the hardening.
Hmm.
So the reason we would do this is because dose attenuates. So we're getting much more dose here, remember, if you remember those lines of distribution from that previous slide. So we're getting much higher dose here from the lateral beam than we're getting over there. Also, we see if we have, well, actually the patient, there's not that much curvature there. We would typically wedge that because we'd be getting a higher dose here from this beam than on this side, right? And because we're getting the same from this, we want to decrease the dose on that side of the beam. So we attenuate it before it gets into the patient. So there's fewer photons actually getting into the patient. So it's not the energy of the photons, it's just purely the number. Yeah.
So these beams, are they sequential or are they at the same time?
So they're sequential because remember that gantry?
Rotate.
We have to rotate the gantry, exactly, and
So why not
sometimes the
just,
patient.
instead of using wedges, why not just blast the patient from both sides?
From both.
Yeah, like
You mean-
spin them and blast them from the other side. Then you don't have to worry about the wedging.
The reason the reason we had that wedging there was because we had to.
But you see what I mean? If you flop that patient around.
Oh, you mean use a four field treatment? Yeah, and we do.
Okay.
We do. And in this case, one of the reasons why we wouldn't say do a 4-field treatment was, say, a prostate case, right? Beaming in from the anterior side to treat a prostate, right? You do have to go through. Actually, no, sorry, that's not true. You would want to go in through the posterior and get this wrong, right? You typically put a beam through the posterior, but not through the anterior. Gosh, I hope I'm getting this right. I can't
I'm sure
remember.
there are biological reasons why.
Oh, absolutely, because you don't want to overtreat the rectum and the rectal wall, which is sensitive and has complications associated with it. You don't want to treat the bowel. You don't want to treat the small bowel, right? So you typically you want to go through. Gosh, I can't remember. I've only planned a couple of those cases up till now, right? But you typically come in laterally, and I'm pretty sure you come in posteriorly.
I'm suppressing my urge to consider the patient as a uniform cylinder.
Yeah. Yeah, that can lead to horrendous complications. So that's one of the reasons why we would do it. But say for a prostate case, typically you could often use a 4-field treatment. So yeah, you're right. So now it's going to start to get complicated because these are the more modern treatments on the bottom. So see, look how nicely that 95% high dose region is conformed to the target volume in both those cases. They're actually here it's slightly better than here, but the difference between these and these is night and day in terms of the amount of the patient that's getting really high doses. And to explain this now this starts to become complicated. So first thing you're going to have to, so this is the MLC. So first thing I'm going to show you is how we can use an MLC to modulate dose. Right? Do you remember how the MLC can create any type of aperture you ask it to? So let's put a piece of film behind this MLC, this multi-leaf collimator, and the beam is going to be coming from where we're looking through that and onto that film that sits behind the MLC. Does that make sense? Okay. So we're going to turn the beam on and irradiate that, and we're going to start the MLC. But the MLC is dynamic. It's going to move throughout the beam. So the parts of the MLC, the parts on that film that spend more time behind the leaf are going to get less exposure than the parts which spend more time in the open aperture, right? So we're modulating the amount of photons that are able to come through and onto that film. So let's remove that and simulate the development of that film. So that MLC is the pattern that I showed you is a very specific pattern, and it produces this. Right? So the differential exposure of that MLC pattern will produce this, and we could go into the agency now and we could run that MLC pattern, and it would produce that image. So that's the first thing you need to understand. Both of these two treatments use modulated photons in each beam. Part 1. Part 2, my second digression, is so we're going to spend some time in post-impressionist painting. You can create this entire image is created like through a system of pointillism. Is anyone here an art major? Can talk more about it than me. So this whole is produced by points. Does that make sense? Like this, 5 more minutes. This
This indicates the precision.
it's not so much the precision. It's a way of you can paint with a brush or you could paint by points. And what I want to point out is that a man called George Birkhoff asked a question. So how could we draw how could an arbitrary drawing be formed by a superposition of straight lines? So can we draw any image we like using only straight lines of variable strength drawn across a piece of paper? Right? And it turns out that you can, and it's mathematically provable. Right? So you can draw images by just adding and subtracting lines of different intensity. So now, and this is the big leap of faith, we're going to take that into the 3D realm. So if we can produce any kind of shape distribution on paper with lines of pencil of different intensities, we can, in 3 dimensions, create different distributions of dose by modulating the intensity of the beam, and summing them up over different angles of the patient. So here is the state of the art. This is a modulated arc beam being delivered for a nasopharyngeal tumor. So this is a head and neck tumor. Right? So here's the MLC pattern modulating. Here's the target over here in red. These are a set of secondary treatment targets. And what you're going to see is, we're preferentially treating this one because we're on that side of the patient. We're shielding the spinal column. And now we're on this side of the patient, we're going to preferentially treat this, and the target is typically open.
The patient is moving.
No, the gantry is moving around the patient. Right? That treatment head is slowly rotating. So you're seeing it from the beam's eye view.
Is this already standard practice? Is it still looking at experimental phase?
It's standard practice for some treatment sites, especially in the head where there's a large number of sensitive structures. In some cases, it's not necessary because we don't really need the kind of conformality that this treatment provides. And here's a quick video. So now you're going to get to see the gantry moving. So this is going to make much more sense to you.
Does this cause pain to the patient?
Pardon me? No, can't feel a thing. That's what's scary about radiation.
Is Varian the main supplier of this instrument?
They are a provider. They're not the only one. Right? So you see so that's the diagnostic beam turning on, right? In order to make sure that the patient is in the expected position, and then you see the treatment beam. Right? So it checks to make sure the patient's in the appropriate position, then it treats. And this one actually has an IR sensor on their chest at the same time, and I'm not going to go into this, but to measure breathing and the effect of that on the motion. Right? So it's extremely sophisticated.
By being more selective, I guess you can increase the dosage. Is that correct? Or
To be,
the more,
I'm going to
the more
skip that
selective
slide.
you can irradiate,
The more dose you can deliver.
the more dose.
Absolutely.
Yeah. So is that resulted in better outcomes?
Yes, in many cases, we've been able to escalate dose, and that's one of the reasons to do this, right? Because remember, I said in the beginning, we're limited by normal tissue toxicity typically. So if we can reduce the amount of radiation we're giving to the surrounding structures, we can boost dose to the target. I'm quickly going to show you brachytherapy, which is a different type of treatment technique in which we actually implant, for the prostate that is, we implant little seeds, and each of these seeds contains some iodine-125, and so the emission is out from each seed. So what's really nice about that is once these seeds are in the patient, there's no dose coming in through the skin. All the dose is delivered over about three months, most of it, by the decay of these little seeds inside the prostate. And they're put in by transperineally through needles with a transrectal ultrasound probe to visualize the prostate. So we do a lot of these implants, 500 a year in BC, and they're very effective. So the team that we work with, so now hopefully you understand something about the process. We have the radiation oncologists. They're the medical doctors. Right? They see the patients. They prescribe the dose. They make those decisions. Ultimately, they're responsible for their patients. There's medical physicists who help to consult and do all the tasks like treatment planning and a few more that I'll get into briefly in the next slide. The radiation therapists, the people who actually work on the units, they set the patients up. They help them. They position them. They align them, and they actually operate the machines. And of course, the nurses. So the things the medical physicists actually spend their time doing: treatment planning, we covered that a lot. Treatment consultation, sometimes there's odd cases, right? Sometimes things are not standard, put the same 3 fields, 4 fields. case, or is a palliative case where they're just going to go to the unit and they're just going to treat them immediately because the patient's in pain and they need to ask you a question. So you do spend a lot of time doing that. An enormous amount of your time is going to be spent characterizing, calibrating, and making sure these machines operate the way they're supposed to work. Because as a physicist, you are the one who understands photon interactions. You are the one who knows or is able to determine how dose distribution should behave, how the treatment unit should behave. So you spend a lot of time making sure the radiation beam is where it's supposed to be, at the energy it's supposed to be at, and most importantly, it's delivering the radiation you think it's delivering. Technique development, I talked about that briefly at the beginning, and of course, research and teaching. So from where you guys are, how do you get to where I am? Right now, I'm here. I'm halfway through my clinical residency at the BC Cancer Agency. I did my BSc in engineering physics at Queen's. I didn't do a CAMPEP accredited MSc, but if you guys do, it's very important that you take an accredited program. UBC's accredited, McGill's accredited. More and more places are going to become accredited because you're going to need that accreditation when it comes time to write that board certification. You could do a PhD. It's a whole bag of worms. You don't have to. In many cases, if you want an academic career, if you want to do research, you probably should. It makes you more competitive, and it's very difficult to get a clinical residency right now. And if you don't have a PhD, you're at a disadvantage. And that's unfortunately the reality if you're really interested in just the clinical side of it, which is really a shame, but many people are forced into that path.
How many positions is there across the country per year?
Residencies?
Yeah.
Or, gosh, that's a good question. Most are filled in by internal candidates. I mean, your chance of stepping into a residency is pretty small unless you went to school there, which is why many people do PhDs. I would say probably each year one position opens.
Across the country?
Yeah, maybe 1 to 3. Yeah, I'm guessing. I mean, there's some in the States you can apply for. But typically that's the case. That's right now. And that's changing. The trouble is many places aren't CAMPEP accredited, and that's just kind of spooling up. The requirements to get the board certification, the requirements for having a CAMPEP accredited program to get your board certification are only now rolling in, so people are just kind of catching up. Okay, sorry I ran late. But if you have any questions, any more?